Alright, here we begin the material for exam 4, your last exam prior to the final comprehensive exam. If you haven't already started reviewing for the final exam, you should probably start thinking about that. And to do that, what you will want to do is take time each week and review your previous study guides for the previous 3 exams. And then also maybe think about making an appointment with me coming during my office hours so that you can review the actual exam that you have taken. Alright, but exam 4 is going to be Friday, April 22nd. The times we had for exam 3 seem to work out pretty well, so we'll stick with those same times, 8 o'clock, 12:05, and 12:15. Now, for this exam, you guys might find it a little easier because there's just going to be 3 systems. The reproductive system, which in this new edition, females are in Chapter 33, and then males are in Chapter 34. Then Chapter 36 will be digestive malfunctions in general, and then really more towards the adult. And then Chapter 37 will do a little bit for just children. 39 is musculoskeletal, and then 40 is musculoskeletal in children. So what you have here with this set of PowerPoint notes is chapters 34, 33, 34, and 36. Alright, so starting with the female system. There's a lot of information in your chapter, but as you read, go ahead and keep these notes alongside of you so that you will know exactly what material to study. So we're going to start with dysmenorrhea. This is simply painful menstruation, indicated by the dys here at the beginning of the word. 2 different kinds, primary and secondary. Primary dysmenorrhea is going to be painful menstruation associated with prostaglandin release, and this is simply an excessive, very excessive amounts of prostaglandin. And so what that does is that increases the myometrial contractions, giving female cramps. There can be constricted endometrial blood vessels, and then because of the combination of those two, increased nerve hypersensitivity, all indicating or giving increase in pain. Secondary dysmenorrhea is going to be related to some sort of pelvic pathology. Alright, that could be any sort of abnormality that comes along over time. So this can occur any time in the menstruation cycle. Generally when you have primary dysmenorrhea, that often is going to start really when menstruation begins. So finding ways to treat this can range from relatively easy to somewhat difficult. Over-the-counter pain medications such as Tylenol and NSAIDs can be helpful. And then if it is too severe, then or oral birth control, oral contraceptives can help to manage the hormone levels. Alright, then amenorrhea is a lack of menstruation. Again, you can have both primary and secondary with amenorrhea. Amenorrhea is lack of, and so failure of menarche, beginning of menstruation, and absence of menstruation by age 13, without the development of secondary sex characteristics. Excuse me, and then by age 15, regardless of the presence of secondary sex characteristics like the development of breast tissue. So, different types of reasons why a person can develop or have primary amenorrhea. There can be anatomical defects. There can be issues with the ovaries, genetic disorders, androgen insensitivity syndrome. There can be involvement of the pituitary gland, right, and result of failure of hormone signaling to the ovaries. There can be central nervous system disorders. And sometimes a female who is just very active in sports or even has an eating disorder that has begun early in age can actually present with primary amenorrhea. All right, and how to treat that is just simply to correct the underlying disorder. Secondary amenorrhea, absence of menses after previous menstrual periods. Common in early adolescence, when the system is just not completely mature, and so those periods are not very regular. Pregnancy is a big one. All right, once a female becomes pregnant, then the uterus is preoccupied with the development of that child, and so menstruation is not desired during that time. All right, and lactation, again, it's an issue with hormones. And then during perimenopause. All right, so the issue is going to be a lack of ovulation. And then this can also be associated with thyroid disorders, hyperprolactinemia, excessive stress, weight loss, and then sometimes polycystic ovary syndrome. And when a person is going to be if a person presents with secondary amenorrhea, pregnancy is going to be ruled out first before they do any further other assessment or treatment. All right, so this is just a nice figure of looking into why secondary amenorrhea can develop. And it's figure 33-2. And generally it's going to be absence of menstruation for 6 months or longer. So, if the person has normal ovarian hormone secretion, then issues for this development could be pregnancy, uterine dysfunction caused by hysterectomy, endometrial ablation, different adhesions. The adhesions could result in a lack of ovulation, decreased ovarian hormone secretion, right? Menopause here, congenital ovarian failure, premature ovarian failure. On the flip side, with the low gonadotropin levels, right, hyperprolactinemia, hypothalamic pituitary issues, and then increased ovarian hormone secretion, right, ovarian dysfunction, feminizing tumors, masculinizing tumors. Again, that polycystic ovarian syndrome. All right, so a lot of it really is going to play into the endocrine system. So here we're bringing both of those systems together. All right, then polycystic ovarian syndrome. This is going to be oligoovulation or anovulation caused by elevated levels of androgens or clinical signs of hyperandrogenism, and then polycystic ovaries. So the ovaries are going to have cysts in them, as you see here with these dark spots via ultrasound probably. Leading cause of infertility in the United States, because with these tumors can block the fallopian tubes, lack of proper ovarian function, and the cause is unknown, but it's thought to be multifactorial, meaning there's several different components that are playing into that female system and the lack of those ovaries functioning properly. All right, then looking into infection and inflammation, the big one is going to be pelvic inflammatory disease. And this can be a variety of specific types of issues. All are going to involve the pelvic area and then inflammation. Most times it's going to be acute inflammatory process that is going to be caused by some sort of infection. All right, it can involve any organ in the upper genital tract, and entire pelvic cavity can be involved in very severe forms. Sexually transmitted diseases migrate from the vagina to the upper genital tract and cause that inflammation. And some of the risk factors associated with developing PID is going to be multiple sexual partners, previous bouts of PID, douching, and intrauterine devices used for birth control measures. Alright, so a couple of definitions. Salpingitis is an inflammation of the fallopian tubes, and the inflammatory process induces changes in the columnar epithelium, and so that's going to bring localized edema, can cause necrosis in that tissue. Gonorrhea is going to be a major player in this in terms of sexually transmitted infections. That organism, because of its physical nature in being a spirochete, can attach to the fallopian tubes and be very hard to get rid of. Chlamydia, also a problem with sexually transmitted infections, and chlamydia will cause permanent scarring. And so with that permanent scarring, regardless of the cause, just if you have this constant inflammation going on, can cause infertility, tubal obstructions, ectopic pregnancies, and then pelvic pain can be associated with it, and eventually it can actually lead to intestinal obstruction. Alright, so here's just a picture of what can happen. Here's the ovary, here's the fallopian tube, uterus, and you can have these different issues of scarring. The bacteria organism can move into the uterus, move into the fallopian tubes, and cause major damage here. This is major inflammation that's going on. You can see the infected fallopian tube here versus the non-infected tube over here. A big difference. And so this fallopian tube is undergoing high amounts of inflammation. Depending on how long that is allowed to last will depend on the long-term damage that is associated with it. Alright, then vaginitis, inflammation of the vagina. Also sexually transmitted pathogens, overgrowth of normal flora such as Candida albicans, so just your basic yeast infection. Protective nature of the female system against such issues can be the acidic nature of the vagina, maintaining cervical secretions, maintaining normal flora, and so when a person takes broad spectrum antibiotics, then the good bacteria in the vagina can be killed off, and organisms such as Candida albicans, the yeast organism, can then have extra room to flourish, extra food to eat so it can expand, and then it's at high enough numbers to cause dysfunction or discomfort is the word I'm looking for. Alright, now this nice, what one would consider healthy vaginal health can be altered by douching, different soaps, spermicide, feminine hygiene sprays, deodorized pads or tampons, pregnancy, diabetes. And so treatment is to develop and maintain that acidic environment, administer antimicrobials, antifungals to clear up the overgrowth of the organism, and then just basic symptom relief. And then finally, with the inflammation issues, cervicitis, inflammation of the cervix. Alright, this can be infectious, non-infectious. Chemicals can be an issue. Chemicals even such as bubble baths. Right? Different components that you might put in a bath because you think it's going to help relax you. Some of it can actually make its way into the cervix and cause an inflammatory response. Alright, mucopurulent cervicitis. Alright, that's going to be actually caused by a pathogen, and so you have mucus/pus exudate that can drain, and then you will want to treat that with antibiotics.